Hi, it's James Carton here, and today this video is about the derm path of Pityriasis rosea. I've got a very nice classical case here to show you, and this came with a fairly typical clinical history as well from a young adult patient who initially presented with a pink, slightly scaly plaque on the trunk, which was then followed by the appearance of more widespread smaller pink scaly lesions predominantly on the trunk, which were fairly asymptomatic really, but a biopsy was performed to confirm a clinical suspicion of Pityriasis rosea. And here is the punch biopsy, which shows fairly nice typical histological findings as well. What we have is, moving from top to bottom, some rather compact orthokeratosis on the surface, but also these small little plaques and mounds of parakeratosis as well, which lack neutrophils in them. And the epidermis is slightly acanthotic and shows evidence of spongiosis. There's nice separation here of the keratinocytes, making the intercellular bridges rather visible there. So nice spongiosis of the epidermis, which in this example as well, actually we've also got a single intraepidermal vesicle here with some Langerhans cells inside the vesicle there, so a little bit of vesiculation as well. And then underneath in the dermis, this superficial and mostly perivascular inflammatory infiltrate, which is predominantly composed of small lymphocytes. And in association with that as well, some nice red cell extravasation here, both in the papillary dermis and also some going up into the lower levels of the epidermis as well. And all those findings are really very typical of what we expect to find histologically in Pityriasis rosea, and certainly with the supportive clinical findings as well, we're able to confirm a diagnosis of Pityriasis rosea. Other things we did as well were, just for completeness, was a fungal stain which was negative. And in terms of differential diagnosis in this sort of setting, I think really some of the main differential diagnostic considerations in this sort of clinical and histological findings, probably number one is usually guttate psoriasis, which can present in a fairly similar fashion as well, with a fairly acute onset of multiple small and scaly lesions, and histologically can also appear rather similar with the little mounds of parakeratosis. I think perhaps in guttate psoriasis one might expect to find some neutrophils within the parakeratosis, and perhaps you might expect slightly less spongiosis in guttate psoriasis, but certainly the findings can show fairly significant overlap between the two entities. Other considerations, well, sometimes drug eruptions can have rather Pityriasis rosea-like findings, and you can get Pityriasis rosea-like drug eruptions, which would appear fairly similar to this histologically. One might expect to find some eosinophils in the associated inflammatory infiltrate, which tend to be absent in typical Pityriasis rosea. And then finally, one other consideration based more on the histology, which can appear similar, might be Pityriasis lichenoides chronica, which can give you some spongiotic changes in the epidermis with some surface parakeratosis and some lymphocytic inflammation in the dermis, again with the red cell extravasation as well. That's very often a finding in Pityriasis lichenoides, the red cell extravasation often extending into the epidermis as well. One feature might expect to find more frequently in Pityriasis lichenoides rather than Pityriasis rosea would also be the presence of some interface activity as well, with some basal vacuolar degeneration and some basal apoptotic keratinocytes. So that finding might be something that might push you more towards considering a diagnosis of Pityriasis lichenoides chronica. And again, obviously the clinical picture may also help distinguish the two as well, but I think those are really the main differential diagnostic considerations in this sort of scenario. But this was a nice example, both clinically and histologically, of Pityriasis rosea.